morning, good afternoon, everyone. Thank you for joining us for this online edition of City Health Conference. My name is Katarzyna Kowalczyk and I'm the director of City Health International, and I'm here alongside David MacIntosh, who was the host of the very first City Health Conference in 2012 in London and who's with us ever since. When we start working on this event, no one would imagine that just within a couple of months the whole world will stop and then turn upside down. We didn't even suspect how significant and prophetic the title of our event would be: Compassionate Public Health for Compassionate Societies. This is our first online event, so we are really excited, and it's even more special as this is the 10th edition of it. So at this critical juncture, we want to ensure that important issues facing our communities are explored with evidence-based content delivered by experts. And evidence-based is something I want to highlight, as now in this era of misinformation and fake news, it is now more important than ever to deliver evidence-based, not fear, not prejudice, not misguided, morality-driven public health information. So I'm grateful to our dedicated speakers for their support in making this event happen. So Ethan, David, Cinzia, Jim, Hannah, Magdalena, Alex, Marewa, Nick, thank you. And now I will turn over to Dave.
Hello, I'm David MacIntosh. I'm Head of Community Safety for the City of London, and I'm also Director of the London Drug and Alcohol Policy Forum. Let me add my welcome to Kasia joining us here at the 10th City Health International event. Now, as has been mentioned, I've had the pleasure of hosting the first City Health International event back in 2012 and have been involved in every edition since, including last year when we had two events, one in Liverpool and also one in Melbourne. Now, last year when we were planning our 10th anniversary event, if you will, we obviously had no idea of the global health crisis that would engulf us all. And I'm very conscious that many of you watching us today will have been directly involved or will still be involved in responses to the pandemic. And I'd like to thank you very much for finding the time to join us, though it is of course a shame that we can't actually physically welcome you to the lovely city of Warsaw. We did consider cancelling the conference, but we agreed it should move online to help maintain the energy and the links which have been built up. And I think it's very important that we do that. City Health has always been about networks and supporting networks of those interested in helping improve the lives of our communities, especially those who are the most vulnerable. And certainly looking at the challenges faced in the health, social policy and political spheres, it's never been more important to share our expertise, our understanding and our experience. The value of drawing strength from each other has never been clearer than in these demanding times. Now, having an evidence base to inform what we do is essential. Funding is a necessity, but without compassion, these resources are unlikely to be well directed and services are not able to successfully engage with those in greatest need. These principles are the foundation of this edition of City Health International. We hope you enjoy the following presentations, plus the Alison, Chesney and Eddie Killoran lecture. And now let me hand you back to Kasia for some details about how you can engage in this year's event.
There are three exciting sessions ahead of us. The opening one, Harm Reduction, the Foundation for a Compassionate Agenda, with Ethan Nadelmann, David Sweanor and Cinzia Brentari. Then, How do we ensure compassion is not lost in a time of austerity, with Jim McVeigh, Hannah Timpson and Magdalena Dąbkowska. Finally, Alison, Chesney and Eddie Killoran Memorial Lecture, delivered by Marewa Glover with an introduction by Alex Wodak. We are also pleased to announce that to support our work and alliances which are at the heart of City Health International, we are now launching the new Global Public Health Network. So GPHN will provide access to high quality information, to discuss potential partnerships, to share ideas, experience, and skills. We are particularly keen to help bridge the gap that often exists between research and service delivery. Our goal, our ambition is to establish a truly global resource to help support advances in public health and harm reduction. A great deal of work has been undertaken on our website, but we recognize it's just the beginning and we need your support and input. So let us know what you would find helpful and please do contribute to its development. And I want to highlight as well that starting with this event, GPHN will run City Health International conferences.
Okay, hello, everybody. My name is Ethan Nadelmann. I'm the founder and former executive director of the Drug Policy Alliance, which has been the leading organization in the US and in some respects globally advocating for reform of drug laws and also for harm reduction. And I've been asked to give a kind of general introduction to harm reduction. I think much of this will be familiar to many of you, but let me just lay it out to you in the way that I've understood it during my decades of study and advocacy, et cetera. So I think probably the best way to think about harm reduction is in terms of essentially four definitions of harm reduction, right? And I think the first one is the one that emerged really in the 1980s. It was the one driven by the spread of HIV/AIDS and the realization that it was spreading to some very good extent in many parts of the world among people who were injecting illicit drugs and sharing their syringes. Right, and who were thereby spreading the disease to people they shared the drugs with, as well as to their lovers and other people that they came into some intimate contact with. And so needle exchange really emerges. I think that the pioneers in this respect are the Dutch, and to some extent folks in England around Liverpool and Merseyside area, but also in other ways around Australia and some other parts of Europe, who quickly realize that there needs to be an enlistment, a collaboration with people who are active drug injectors, and the realization that we need to transform the injecting drug user, the illicit injecting drug user, from a deviant worthy of being persecuted and prosecuted into a partner in a public health campaign to reduce the spread of a deadly disease for which we have no cure. That's really the origins of needle exchange. The simple approach to saying, here's a clean, throw your dirty syringe, here's a clean one. The sort of grassroots up thing that you began to see in the Netherlands in the 1980s, where they just, even before the evidence emerged, but eventually the evidence, of course, does emerge that this is a policy that ultimately helps save lives. And that at the same time, there's no evidence that it actually increases the extent of illicit drug use. Now, definition number two is the one that applies this basic notion of harm reduction, of reducing the negative consequences of a risky, dangerous, immoral, disapproved activity, of reducing the negative consequences as much as possible without generating other sorts of intended harm. So it's harm reduction as bicycle helmets or motorcycle helmets to reduce the risk of those activities. It's harm reduction as seatbelt laws and encouragement to wear seatbelts. It's harm reduction as naloxone, making naloxone more widely available to reduce the number of overdose fatalities. It's harm reduction as methadone maintenance, but not necessarily methadone and buprenorphine maintenance in a very constricted, restricted context, but instead methadone maintenance in a more harm reduction way, a way of acknowledging that people need to approach this sometimes in a step-by-step manner rather than just making that instant switch. But it's all about reducing the harms of those activities. There's maybe an apocryphal story. Some of you have seen these pens here. I remember as a kid, we would also, and maybe other things, you put these pens in your mouth, and every once in a while, so this top would get dislodged and could lodge in your throat and choke. And if you think about the approach for children in school, there's one approach, which is the just say no approach. Johnny, stop sucking on that pen, get it out of your mouth. But I don't know if the story is apocryphal or not, but what happened, I believe, with the construction of these pens some decades ago was they started to put a little this top of the pen was no longer solid. There's actually a little kind of air passage there, so that if you jammed the thing in your throat, you could still keep breathing through it until you got to the nurse's office and they could dislodge it. That's a sort of pragmatic approach to harm reduction. The third approach to harm reduction is really the policy definition of harm reduction and what might be called the balancing approach to harm reduction. It's that harm reduction aims to reduce not just the consequences of illicit drug use, or not just the consequences of a dangerous activity, but also to reduce the negative consequences of the policies directed at activity. So, for example, the optimal drug policy, in my mind, it would be that seeks to reduce both the negative consequences of drug use per se, of the use of alcohol, tobacco, marijuana, heroin, cocaine, what have you, and the negative consequences of the drug policy itself. Of incarceration and arrest and suppression and repression and the cost and the money being spent on all the efforts directed at that. It's the understanding that the optimal policy achieves that best possible balance, right? And if you think about that, one way to think about this is not just with respect to illicit drugs, but I sometimes think about one of the most, I don't know if we call it the addictive or dependent activities in the world, which is or objects, which are automobiles, right? I mean, we almost all use automobiles. We rely on automobiles. We depend upon automobiles. We love automobiles, yet automobiles are also responsible for incredible levels of death and devastation and environmental harms and other sorts of harms in our society. And one thing to realize, we tend to think that the best way to reduce the dangerous aspects of an activity is to reduce the cumulative amount of participation in that activity. But what you can see in many parts of the world over recent decades is that when it comes to automobiles, the number of cars being driven, the number of cars on the road, the number of passengers and drivers, the number of miles being driven have all increased in many parts of the world, even as the harms associated with automobiles, even as the deaths, the accidents, what have you, have declined. Through better designed cars and better designed roads and through seatbelt laws and better driver education programs. What we see was that we were able to reduce the harmful consequences of this risky and dangerous activity, even as the total participation in that activity continued to grow. I think that's an important model for us to keep in mind when we extend the definition of harm reduction to a whole range of other activities. Now, the fourth definition is really the ethical one. And I would divide that into part A and part B. Part A is both ethical and pragmatic. It's the notion that when you want to reduce the harms of a risky or dangerous or immoral activity, you have to meet people where they're at in a non-judgmental way. It's sort of the opposite of the kind of 12-step only, abstinence-only approach that greets a person who's addicted to drugs at the door and says, I cannot help you until you're willing to stop using drugs. Instead, it's the alternative that says, please come in, let me try to help you. Let's figure out what are your goals and your objectives in life, apart from reducing or ending your drug use. And let's aim towards those objectives, working together to reduce the harms of that activity in your life. It's a fundamental element of the harm reduction practice. Now, part B of the ethical definition of harm reduction is the human rights element. Remember, keep in mind that one way to think about a defined harm reduction is that place where public health intersects with human rights. Public health, taken to its logical extreme, is potentially a totalitarian policy. It almost emerges in response to plagues, right? On the other hand, human rights, until the last decade or so, really did not recognize drug use as something sort of as part of its list of areas where human rights should be defended and articulated. But if you think about it, and it's a fundamental ethical belief that I believe, and I think millions of people around the world believe, it's the basis that nobody deserves to be punished or discriminated against or amongst based solely upon the substance they put in their body, right? That nobody deserves to be punished simply for what I put in here. It's that fundamental notion that I am sovereign over my own mind and body, and that government, in trying to reduce the harms of drugs, must find a way to work around this fundamental human right that whereas you may hold me responsible for the harms I do to others, you should not be punishing me or discriminating me based upon which substance I choose to put in my body. right? It's talking to the mother or the parent who, God forbid, has two kids struggling with drug addiction, one to alcohol and the other one, say, to heroin. There is no basis in science, in medicine, in ethics, or even for that matter, in the Bible, in saying to that mother, we need to treat your alcoholic son fundamentally different than we treat your heroin addict son. No basis whatsoever. I think when it comes down to it, those four definitions of harm reduction are the ones that have really shaped my thinking and my advocacy in all of these years. And I think we all know the obstacles to it. It's the belief that the activity itself is immoral and must be stopped at all costs. It's the belief that abstinence is the only acceptable approach rather than a legitimate objective of one's, drug policy or drug use. It's the notion that allowing harm reduction would encourage more engagement in this risky or dangerous or disapproved activity. But ultimately, what we see is that those objections turn out to come at the cost of really millions of lives around the world. And it's why I fought for harm reduction with respect to illicit drugs and heroin and drug addiction. It's why I fought for regard to marijuana and ways to reduce those harms. And it's also why I find myself these days really pulled in to the fight over tobacco harm reduction and the recognition that e-cigarettes and heat-not-burn devices and things like that may be the most effective way to reduce the negative consequences associated with the consumption of combustible cigarettes, even if it results in some increase in the cumulative nicotine being consumed in global society. So I'll stop now, and I look forward to engaging in the Q&A following the presentations by my two colleagues. Thank you very much.
Well, it's great to be back at a City Health International Conference, even if done remotely. This is saving me the travel expense and the jet lag, but I'm sorry I'm going to be missing seeing people in person. I was asked to talk about trust rather than fear, that empowering people rather than trying to control them or scare them. And I think this is a really key issue when we look at a lot of areas of public health and indeed a lot of areas of social policy. And it's been one for a very long time, that there's been this long tendency to look at things more in moralistic terms or authoritarian terms, telling people what to do, demanding that they behave in certain ways, rather than empowering them, working with them. And we've lived it. I mean, if we look at everything like the Inquisition or the battle that we had on the whole history of other public health issues, it's always been there, and it still is. So right now with COVID, we're living it. I mean, even here in Ottawa, which is like a advanced, wealthy, progressive city, the immediate response to the COVID problem was an authoritarian one, not a public health one. It was, we better ban people from going into parks. There's no evidentiary basis for doing that. There's very good evidence to say that's a really bad idea. We'll tell them to just stay home. Lots of evidence that's a really bad idea, but it's a very authoritarian idea. It wasn't about promoting health and meeting people where they are and understanding their lived experience and the sort of things that the Ottawa Health Charter, adopted by the World Health Organization back in 1986, made clear, that it's a process of enabling people to make better decisions about their own health. And all that seems to just get thrown out the window as soon as some crisis comes along. And I think trying to understand that, because that's what we've lived on all these issues, whether the current ones, such as dealing with drug policy, dealing with incarceration policy, dealing with nicotine, dealing with alcohol, dealing with sexual behaviors, but the history of so many other things, whether it be coffee or farm mechanization or even bicycles, that this tendency to look at things as it's a moral issue and we have to be authoritarian. Where does it come from and what can we do about it? And it's an area that has intrigued me all my career, and that I've worked on trying to reduce cigarette smoking since 1983. And embarrassingly, this should be a really simple issue. We knew by the time I started working in this field, people smoke for the nicotine, they die from the smoke. So simply dealing with the dirty delivery system would essentially solve the problem, our leading cause of preventable death. And here we are, almost 40 years later, and we haven't done it. And in fact, many of the people who claim they're working on public health adamantly oppose giving people a safer a system of getting nicotine. So we've lived this on nicotine. We've lived it on illegal drugs. We've lived it on so many things, and it's gone on way before any of us were born. Does it have to continue way after all of us are gone? So I think trying to understand, where does it come from? Why do we have these principles of public health that are ignored even by a lot of very senior people who are doing or say they're doing public health work? And I think to begin with, we can look at the sorts of things that work. So public health principles about empowering people, to facilitate them making better decisions about their health. It works really well. The principles of the Enlightenment, the sorts of things that Pinker writes about in Enlightenment Now, has been phenomenal. The increase in life expectancy, in quality of life, in health, in wealth, that if we pay attention to science, if we use reason, if we use humanism, we really, really get somewhere. And yet, whenever a new idea comes along, with saying, here's how we could do something better, or what you're doing now is not the most effective thing to do, like trying to say, actually not fining people for walking in a park is maybe a good idea if we're trying to promote health. Every time a new idea comes up, there's opposition. Thomas Kuhn wrote about it in The Structure of Scientific Revolutions. Paradigms, people get attached to a certain way of doing things. They look at anything else as a challenge. It can be a threat to their standing. Juma talks about it in Innovation and Its Enemies. Virtually any new form of innovation is not just attacked, but attacked viciously. And the people will have vested interests. People will have professional interests. People will just not like change, but they will oppose these sorts of things. And they oppose them even more when they see some sort of moralistic reason to do that. The view that, well, of course we have to tell people not to go to a park, because what if a whole lot of people went in and then they got too close to one another? And you can't trust people, in Toronto, they put a fence around this huge park because we were afraid if people went into the park, they might stand too close to one another. That's one of these moralistic, authoritarian, stupid ideas. It's completely foreign to the principles of public health about empowering people. So when we're facing something like that, trying to understand, we know it's happened historically. Why? And I think part of the answer to that is, what we know now from things like thinking fast and thinking slow, that we tend as a species to come up with very quick, emotional, moralistic responses to new information or situations. So our amygdala is making rapid decisions. And then our frontal lobes are often used just to try to justify it. Like, I don't like this, and here's why. And we also know that from moral psychology that people have different operating systems. So we're often talking at cross purposes. So public health is usually built around the idea of autonomy. Give people the information they need, empower them, facilitate them to make better decisions. But there's a lot of people who see the world in terms of authority, that, what does somebody else say that I see as an authoritative source? What does the church say? Or what does the World Health Organization say? We just have to go with that. Other people have this sort of purity sanctity view and it's very moralistic, of what you're saying is offensive. It's sinful, it's bad. And people respond in different ways depending on what their moral, psychological operating principles are. And we need to know that. But I think one of the biggest problems we've had, and Levin's new book, A Time to Rebuild, talks about this, that we went from a time that institutions, education, research, science was something that would mold our thinking. You know, we would adapt. If you're going to be at a university, what are the ways you should be trying to think things through? If you're writing papers, what's the role of peer review to hold you to account, to make sure you really thought this through? That, you know, if you're working for a major institution like, say, the World Health Organization or the Centers for Disease Control, what are the standards you have to meet in order to really be an acceptable employee there? You know, that was the mold of, you know, shaping the way that people would act, would behave, would think things through. But that seemed to get replaced with platforming. So instead of people saying, how can I become a better scientist to adhere to the standards of this organization, it's more like, great, now that I'm at the World Health Organization, I can get even more Twitter followers and I can really broadcast my views to the world. This allows me to say more how I feel about things. So you took a lot of that moral psychology, that, you know, that quick thinking stuff, the moralism, the authoritarianism, and you simply gave it a platform. That I think that's why we end up with people working for organizations that are doing things that are really counter to public health. But it fits this personal ideological perspective they had and haven't had it sufficiently questioned. So we end up with even more of a problem. Like, what happens when people running organizations or working for organizations like the World Health Organization take essentially moralistic, anti-public health views about something and have the platform of working for the World Health Organization? So this creates a further challenge at a time where social media is adding to the challenges, because misinformation is coming out, starting in many cases as disinformation, things that people are doing to purposely confuse someone, that is then being passed on by someone you trust who fell for it. And now you fall for it because you trust the source. It turns into misinformation. And so we end up with a lot of garbage research that isn't held back by decent peer review, because universities become a platform rather than a mold. And then we end up with that information being passed on by what's seen as an authoritative source by people who believe in authority or trust the source that it's coming from. And we end up digging ourselves into a hole. And it's how we end up not questioning things like whether it's okay to walk in a park, where fear ends up being used instead of building trust. And it's a very powerful thing. So we had far more people calling snitch lines about people doing totally healthy things in parks than there were people protesting against, why on earth are you banning me from going to a park with my kid? So how do we change some of that? And I think the optimistic view of this is that many things have changed. Our views on so many things change. They change quickly. They change dramatically. If we look at attitudes toward interfaith marriages or interracial relationships or sexual orientation or attitudes as to how do we deal with something like AIDS, we have seen those changes. I think what we need are people to challenge, to look for evidence, to demand evidence for the policy somebody's trying to bring forward, to challenge authoritarian responses to any of the challenges that we face, and to fight back against institutions that allow platforming, that allow somebody to misuse the position they're in to promote a personal view rather than adhering to the science and adhering to public health principles. I think if we do something like that, we start to make a real difference. We've done it on many other issues. We can do it on the issues we're facing now. Thank you.
Good morning, everybody. Hi, and thank you for joining this online version of the City Health Conference 2020. My name is Cinzia Brentari, and I am recording today from Italy, from home, the place where I've been working, like many of us, over the last couple of months, working amongst other things on harm reduction projects. I've been involved in the harm reduction world let's say, for almost 20 years. And this is why I will contribute to today's discussion just with a couple of reflections coming from my experience, let's say my journey with harm reduction. A journey which started in 2001 when I joined the European Commission in Brussels, and I first met harm reduction and the word harm reduction. I was working in a department of the European Commission which funded projects to developing countries on drugs. The drugs agenda of the European Union was at the time very much based on the two main pillars of drug demand reduction and drug supply reduction. And I clearly remember the words from my boss at the time of the European Commission. He told me that we were funding these pilot new projects on harm reduction, but we were not really wanting to have the harm reduction word included yet in our policy agendas. So those were still times where not everybody would accept even the term harm reduction. But the European Commission allowed me to get in contact with harm reduction in practice. Those are a few pictures which come from my early days at the European Commission. In 2003, I started missions in the field to visit harm reduction projects in developing countries. I went to Latin America first, Colombia, Mexico, the Caribbean region, and then I moved on to other organizations to work on projects in Asia, in India, and for many years in Iran, where I monitored harm reduction projects. And those are pictures which make me think very much of the core theme of the City Health Conference this year, which is a compassionate agenda. And I think compassion was one of the feeling that you could see in the eyes of these street workers here, outreach workers, people who would go out in the street and meet drug users, look up for them, find them, talk to them, listen to them, providing life-saving items like clean needles and syringes and condoms, and sometimes purely a sandwich of a cup of warm tea in winter times. And compassion was also something which the communities of people who use drugs used to look at each other, to take care of each other, and basically to stay alive. This was the main objective in some of the very harsh environment in which these people, drug users, were living and still are living today. So I fell in love with harm reduction at the time, really, and I started studying it more deeply. And I then learned a lot about the idea that harm reduction is a public health priority. Harm reduction saves lives, harm reduction works, harm reduction is cost effective. We used a lot the cost effectiveness element for a number of years to try to convince policymakers that it would make sense, even from an economic perspective, to invest in harm reduction, spend less money today, but invest in harm reduction so that you have a big public health gain in the future. So the public health priority was something we would look on in terms of research, in terms of producing the evidence, in terms of disseminating and sharing the evidence. We were working a lot with UN organizations, WHO, UNAIDS, UNODC. They were all compiling and disseminating evidence about the fact that harm reduction works. And this was very much important for my work at the time when I worked on prison health. I've had the privilege of running for a number of years European networks of third sector organizations, researchers, and prison administration working on health in prison, trying to discuss together on ways to improve the health of people who use drugs when they ended up in prison. And the harm reduction agenda was very much there. And the bullet point that you see in these slides, funnily enough, are bullet points which stayed the same for a number of years. And I would copy and paste this slide over and over again, from presentation to presentation, when I traveled around Europe to talk to prison administrations, to prison doctors, to harm reduction workers, to policymakers, to public health workers, and showing them the evidence that needle exchange could be easily and safely introduced into prisons, and that it was effective for the health of prisoners, the health of people who use drugs, but also the health of prison workers, that it was safe for prison staff, and that it was a gain for the whole community. And then moving on again, I realized that evidence is not enough. It would have been nice to convince our policymakers purely through the lot of evidence that we had. But there are two other core elements which are needed if we want to foster a harm reduction agenda, elements which are mentioned here. Funding on the one hand, core to fund harm reduction services, and what I call here political wisdom, and I'm not sure this is the right word, but for me political wisdom means the capacity of our policymakers, of our governments to look for the future, to have a vision, to use that evidence to transform this into policies which work for the general interest. This is what we should be looking for when we think about policy making. When it comes to funding, the striking case which comes to my mind, because I lived it, I was working on that, is the case of needle exchange in prison in Romania. We had worked for many years to introduce this service in Romanian prisons. We had created the political environment. We had passed, Romanian colleagues had passed legislation. We, through international projects, we had trained prison doctors and prison administrations and peers in order for the needle exchange to start, which happened. And services were running around different prisons in Romania until the Global Fund money ended for Romania. Between 2010 and 2011, the Global Fund program stopped. And Romania is a clear case amongst the many others of a country which was not ready, of a government which was not ready to sustain the investment made by the Global Fund, which meant that most of the harm reduction services reduced substantially or stopped. And if I think of the years of investment to start a very difficult harm reduction service such as needle exchange, and the rapidity in which it was dismantled, you think that sustained funding is something which is really crucial, as well as political wisdom. And when I think about political wisdom, I cannot but think of my own country, Italy, where I moved back in 2009. And then I started working with the Italian harm reduction network and with third sector organizations here running harm reduction services. And I realized that really third sector organizations are still striving today for the recognition of the harm reduction agenda, and that we managed to introduce harm reduction services only recently in the basic minimum standard for services in the public health sector. And this nice black and pink campaign here, it's the campaign by Harm Reduction International, which looked at both elements, funding and political wisdom, because we called for a redirection of resources, a redirection of 10% of the resources which are devoted to the fight, to the war on drugs, by 2020 would have substantially helped in reversing the HIV/AIDS epidemic globally, which clearly, unfortunately, did not happen. And the human rights angle to harm reduction is something I learned more recently, again through my work as senior advisor to Harm Reduction International. Discrimination and marginalization of people who use drugs is something we've heard many times. They treat us like dirt, says these Russian drug users, but we have a lot of testimonies from people who use drugs about this. And I very much like the statement from Professor Paul Hunt, who's a former UN Special Rapporteur on the right to health, And for him, harm reduction stands as a clear example of human rights in practice. And this is very nice. It makes me go back to my early days and my experiences with those street workers and outreach workers. What they were doing then was really putting harm reduction in practice. And when we talk about putting human rights in practice, and when we talk about human rights with reference to harm reduction, we talk about the right to health, the right to non-discrimination, the right to equal treatment, the right to life sometimes. So we really need to keep the human rights angle as core to our agenda in looking to further work on harm reduction. And then we come to these difficult times. The COVID-19 emergency times, an emergency, a pandemic which has impacted heavily on the global agenda from very many different perspectives. It has an impact, of course, on people who use drugs. There is an increased risk for drug users and marginalized populations these days. There's been a heavy disruption of harm reduction services around the world. There will be an impact on funding with a redirection of donors' funding towards the emergency. So we really need to watch out so that core funding stays in place for harm reduction. And as I read through a number of authors these days, there's a lot of people who argue towards the idea that we should use this opportunity, this emergency time, as an opportunity to rethink, to approach our life and the world and the future in a more meaningful way once we will be starting to get out from this emergency time. And I think a combination of the elements that we've been going through today, and that we will surely listen from the other presenters to this meeting today, will be needed in order for us to look ahead with a clear focus on a harm reduction agenda. Thank you.
Okay, well, thank you and welcome to this, the first Q&A session. Thank you, Ethan, David and Cinzia, for a tremendous introduction. I think you set out the various principles of harm reduction, some of the intellectual underpinning for compassionate approaches, and also provided a sort of clear insight into some of the barriers, but also the practical benefits that harm reduction can provide. Now, we have got a number of questions, and I'm going to start off with one here that goes back to Ethan's presentation, but I'm going to invite everyone to contribute. Do you see a distinction between harm reduction and harm minimisation? The example given here is using your pen cap. So telling Johnny not to suck the pen cap would be an example of harm minimisation. Producing pen caps with holes in them is an example of harm reduction. But I mean, I guess I've worked in areas where when we have used the expressions, have often used them interchangeably, but I'd be interested to know if you do see a difference.
Yeah, no, I really would use those phrases interchangeably as well. I remember going back, to the 90s, et cetera, early 2000s, there was all this debate about exactly what should we use the phrase harm reduction, harm minimization, risk reduction, risk minimization. There were sometimes efforts on the part of abstention-only people to say abstention-only policies were harm reduction. There's been a big battle on that, but I think that as we're making our best efforts to try to advance the philosophy of harm reduction, I think it's more important to stay focused on the core principles and not get so concerned about the specific wording.
Okay. Cinzia, David, do you want to come in on that?
I would agree as well, if I can. And I think that Ethan's presentation about the full meanings of harm reduction gave us such a variety of angles in which you can interpret harm reduction that I would agree. Let's stick to the core principles and do not get involved into differences between harm reduction and harm minimization. Also, the harm reduction approach changes so much according to the ways in which policies change, in which drug use change, in which settings change. So I would also agree that focusing on the core principle is what we really need to do.
Yeah, I agree. Essentially what we're doing is whenever we see risk, we try to reduce it. And that's a really pragmatic approach. We do it, within the confines of empathy, trying to understand what motivates people to be doing what they are. How do we empower them? So I think it's simply a matter of, in principle, we're being very pragmatic and reducing risk wherever we find it. We can call it whatever we want, and we do use some terms that can get some people very upset because it's contradictory to the views they have about how people should behave. But essentially, it's just pragmatic. Call it what you want.
Yeah, let me just add, I just remember going back, there was always this dilemma with the phrase harm reduction or harm minimization. On the one hand, the strength of the phrase is that it's very hard to be against it. Who could be against reducing harm or minimizing harm or risk? On the other hand, and especially in the US context where we think about advocacy and rallying people, reduce the harm, minimize the harm, it's not exactly bold language that inspires people to action. And so that's been the traditional dilemma in advocacy in this area.
I've got a question that leads on from that, and I'm going to direct it at Cinzia to start with, because in your presentation, you spoke about when you began at the European Commission, I think, about how the phrase harm reduction or minimisation wasn't really used that much in policy. And that question's been raised. And I have to say, when I worked in central government, and I've gone back and looked at strategies which historically have been described as being very harm reductionist, the phrase was hardly ever used, and we still hardly ever use it at national level strategy, in national level strategy documents. Is it because, like Ethan's just said, it lacks focus, or are people still slightly wary about the whole term harm reduction at a policy level?
Well, I think that dates back in time where the policies were changing, and it's true that policies of the European Union have changed a lot since the times I was there, I have to say. And the European Union for a number of years in the following years has been a champion of harm reduction. I think it has allowed harm reduction concepts and services and policies to be raised up at a higher level. It facilitated networking of civil societies. It created networks of experts who supported the construction and the fact that we could build harm reduction into drug policy in general terms. I saw it happen, really. At the time I joined the European Commission, it was back in 2001, I think they still did not have a clear idea. But the fact that they started funding some projects which allowed them to see how harm reduction works in practice and which were the benefits of harm reduction made it also into the policy. So allowed the European Union to have a more balanced policy on drugs, which included a number of different angles. And it has remained so for a number of years, I have to say. Maybe less now, unfortunately, but it has been strong and really helped the development of the concept at European level.
If I could just add to that, I think another issue that happened, especially in the earlier years, was that the opponents of harm reduction deliberately conflated harm reduction and drug legalization, by which they oftentimes meant free market drug legalization. And I think it was a powerful effort on their part. It happened very much in the United States and the federal government. It definitely influenced the way that UNODC and its predecessor agency shaped this. It was a little bit understandable. There were prominent people, advocates like myself and others, who were simultaneously deeply involved in advancing basic harm reduction and also engaged in the debates around drug legalization. But none of us were free market drug legalizers or all this sort of stuff. But you could just see these incredibly disingenuous efforts. I mean, some of it was naive, but mostly I think it was informed and disingenuous on the part of major officials around the world, especially US, especially Vienna, really saying, oh, harm reduction is just legalization in sheep's clothing and things like that. And I think eventually that just has faded a lot more, where that's much less of a concern these days.
I have to say, Ethan, you've just answered another question that had just come up there very directly about the problems sometimes between harm reduction being linked to drug law changes. I've got a question here for Dave Sweanor about whether you're genuinely optimistic about seeing a better quality of debate, particularly around tobacco harm reduction, when so many of those involved have such very deeply entrenched positions.
Well, I suppose this can go either way. I mean, when we look at the history of what's happened with technology advancements in reducing risk in other areas, risk reduction usually wins out, often fairly rapidly, and despite the opposition. And I think that if we look at this in the context of a very long history of a whole lot of things where we have reduced risks, the sort of stuff that Pinker has written about in Enlightenment Now. Why the people who are saying they oppose harm reduction would never get in the sort of cars that were designed 30 years ago because they weren't safe enough. They meet in buildings that meet building standards, so they're far less likely to fall down. They're taking trains on rails that no longer have snake heads, that where the top of the rail comes up through the carriage and kills people. They drink water that's been purified. And amazingly, many of these things were opposed at the time. And again, for these sort of moralistic behavioral types of reasons. So I think the history is on our side, that you eventually win out. But then, as Ethan can tell us, that on some issues, like what's happened with the war on drugs, it can go on for a very long time. It can go, I think we're finally seeing the end of that approach. But, it's been decades. And when there's a tremendous amount of political power and money behind those who are pushing a behavioralist, moralistic approach, it takes longer. And that's what we have now. So I think it takes a strategic approach by those who are really promoting health to look at how do you counter this. And I'm optimistic that we can do that, to be able to deal with the arguments that are made against taking a pragmatic approach.
Thank you. Ethan, there's another question directed at you, which says, are you not concerned that harm reduction can actually make drugs more popular and increase the harms there?
We actually have very powerful evidence on this, right? The argument that was used against needle exchange and better access to sterile syringes in the 80s and 90s was very much that it was condoning and encouraging illicit drug use and drug injection, and in fact would increase that activity. And fortunately, the studies came out showing, no, that's not the case, that making sterile syringes more readily available through legal channels, exchange programs, and pharmacies, in fact, would effectively reduce the spread of the disease without increasing drug use. But I think there is the possibility that at times it may result in a greater amount of activity. It's possible that when one introduces mandatory seatbelts, that people might drive a little faster. It's possible that when one introduces designated driving norms with respect to drunk driving, that people may be more likely to get drunk. It's possible that as we're introducing, in fact, we know as we're introducing e-cigarettes, that there's this all of a sudden proliferation of young people using it. It's why harm reduction focuses not on the cumulative amount of participation or use in an activity, but rather on reducing the cumulative harms. So that effectively, even if use goes, even if harm reduction policies result in the cumulative participation or use increasing by 5 or 10 or 20% or whatever, so long as the cumulative harms of that activity are going down, that's what's really important.
Thank you.
I think there's a really nice summary of the issue, I think, in an article that Professor Julia Marcus has recently published in The Atlantic. She's at Harvard Medical School. And she was talking about harm reduction in terms of how we deal with COVID, but brings in the experience in dealing with a whole lot of other issues. And just a quote from that, it says, in all of these examples, a concern about the promotion of risky behavior masquerades as a concern about health. But in reality, resistance to harm reduction is typically a cloak for moral judgments about what constitutes responsible behavior. And I think that's what we're really looking at. So people are not concerned about the harm of the use of a drug or an automobile or a bicycle or various other things people have opposed risk reduction on over time. They're concerned about the behavior itself. You shouldn't be doing that. You shouldn't be using nicotine. Therefore, I will argue about how this could increase risk. But what I really mean is I don't like your behavior and I'm going to tell you how to live.
Okay. We've actually got one question that leads on from that. Are there any lessons from harm reduction for the way that countries manage the COVID-19 problems?
Oh, I can say I think there's many because I've been dealing with some of those. There's still this tendency that when you have a problem, that some agencies will, some groups will move to an authoritarian response. It's evidence-free. They want to tell you how to live your life, and they're concerned about behavior, and they'll talk about it as increasing risk. So the way that even here in Ottawa, we had a municipal law passed that to deal with COVID, you were allowed to be in a park only if you were going through that park to get to somewhere else, but you were not allowed to linger, to play, or to engage in any other activity with fines of $900 for doing it. There was no evidentiary basis to that. It's not based on health, it's anti-health, but it was very much the, I'm gonna tell you how to live your life. And I think any of us who have dealt with vaping, could see how measures like that could come forward. And the Atlantic article is actually talking about some of the issues on COVID, that when people are saying, just go home and stay home, it's not going to work. What can you do that's pragmatic about get out for a walk, but physically distance? That's risk reduction. That's meeting people where they are, and it's viable.
Thanks. Would David or Ethan or Cinzia want to come in on that?
I've been speaking. Cinzia, any comments?
Yeah, I think the danger of the authoritarian approach has very much been there over the last few weeks. We've seen that against the idea that a harm reduction approach is a pragmatic approach. So we need to find ways to get to people where they are at and helping them and empowering them in making informed decisions. And I'm not sure this is what have been always done in the last few weeks from our governments. I also think that the harm reduction lesson is about not leaving anybody behind. So the idea that the lockdown, for example, in the COVID time has affected differently people according to their health status, according to their being rich or poor, according to their having a home or not. Homelessness has been a huge issue during COVID time. So I think the idea of not leaving anybody behind, it's another one which we should look at, and we will have to look at it in the recovery which comes after COVID.
I think we also, it's a little ominous going forward because, we now look at many of the countries in Asia, some of which have been more authoritarian in their approach, as having been more successful in dealing with COVID, and that therefore maybe the model is that authoritarianism works best, what China did or some other countries. And I think the issue we have in Western, more tolerant societies is that because we can be irresponsible in our policies rather than being pragmatic. And so, the real challenge in the West, I think, in more open societies is how to rely on fundamental pragmatism and on evidence. It's what David was talking about in the Ottawa context. It's about, yes, these authoritarian instincts kick in. Yes, there's a tendency to avoid, and I think in my third definition of harm reduction, where I talked about harm reduction as policy and reducing both the harms of drugs and the harms of government policies. And similar with COVID, the challenge is reducing the harms of the virus as well as the harms of the government lockdown responses as well, and that one needs to achieve some balance. And balance is something that's somewhat evidence-based, somewhat subjective, but it's obviously something we need to get ever better at. And the more that we can be good at articulating that principle and employing good leadership in order to do that, I think the more likely we will be to succeed in open societies.
Thank you. There's another question directed at you, Ethan, where refers back to your presentation and describing an optimal drug policy. And the question is, which government is closest to achieving that right now?
Well, I mean, the models really have come mostly out of Europe. Sometimes Australia, New Zealand, Canada have shown some real progress as well. But, when I oftentimes think about the three leading pioneers of harm reduction, one was the Dutch, beginning in the late 70s and then the early 80s, first with respect to cannabis reform and a kind of thoughtful decriminalization model, not just with respect to possession, but also the sale. And then being among the first to respond effectively to the spread of HIV among injecting drug users by just, having a harm reduction social service centers where there'd be two buckets and people would be encouraged to toss a dirty needle in one and put another one, and pick up the clean needle in the other. The second model, I think, was very much Switzerland in the mid and late 90s, which introduced, it tried the US law enforcement police model, but then it said, this is not working here. And they then were pioneers with respect to safe injection sites, with respect to prescribing pharmaceutical heroin, with respect to emphasizing a real public health approach. And the third model was really what Portugal did in the beginning of the 21st century, where they introduced they basically made a commitment not to legalizing drug possession under the law, but essentially adopting a policy that said we are committing not to put anybody behind bars simply for drug possession, and we're going to treat this primarily as a health issue. So I think those have been three major models, and I'm now somewhat inspired by Vancouver in British Columbia, which has introduced an active discussion around safe supply in the face of a major opioid overdose epidemic. They're trying to be as resourceful and innovative as possible, and that includes making available the sorts of opioids that illicit drug users want, but making them available from legal sources in order to reduce both street criminality and disorder, as well as overdose fatalities and other health ills.
Okay, Cinzia, Dave, you've got anything to add to that?
Yeah, again, it's being pragmatic. I mean, what works, do it. And we just have so many examples on so many topics. And the real exception is like what we're encountering now with alternatives to cigarettes, where people are saying, we'll ban the safer alternatives. And, it's sort of like going back to the mid 1800s and saying, so when John Snow figures out, what's causing cholera, is the response to say, well, we'll leave the handle on the Broad Street pump, but take it off all the other ones. What you do is you go after the high risk stuff. You try to move people to low risk activities. You don't ban them from doing the low risk stuff and force them to do things that are going to harm their health.
Okay. I've got a question that is aimed at Cinzia here. And actually there's two questions which I'll try to blend together. How can those working in countries which have less well-established harm reduction approaches best support colleagues in areas and countries where both services and policies are perhaps less well developed? And then there's a specific question about tobacco harm reduction in sub-Saharan Africa, but perhaps if we deal with the general point about harm reduction in general and then broaden it out to the tobacco harm reduction.
Well, I think I've been spending most of my time in networking work, and networking can happen at different level and at different times. Countries where, speaking about my own country, Italy, for example, where people still do fight for harm reduction to be recognized. The coming together of civil society organizations is very important. So we need to strengthen our network, to strengthen each other, to become more strategic, to learn better how to address the needs of the networks, the needs of the people in the field, and also become more strategic in advocacy work towards our government and towards the international policy environment. So I do think that trying to get any opportunity to network among civil society organizations is a key. It's a key issue, and nowadays there are many opportunities through networking conferences and projects to do this. People witnessing other people, other peers providing services in different countries has always been, in my experience, a great learning opportunity. So witnessing the fact that you can actually do this, and it's not so difficult to do, keeps us strong in our motivation to continue advocacy, which we do not have to lose, because change takes time. And advocates for harm reduction need to continue fighting and not lose their hope and the motivation that they have in the harm reduction policy and the belief they have, because we will need to continue fighting on this field.
Thank you.
If I could just add to that, I think when you're looking at, especially in developing countries and countries with dramatically more limited resources, yes, on the one hand, harm reduction can be expensive to the extent it requires providing basic services to people that societies and governments have a hard time affording. On the other hand, when we go back to the basic idea of harm reduction as pragmatism and respect for human rights, what you begin to realize is that punitive prohibitionist policies are oftentimes quite expensive. It costs money to rely heavily on police and jail. It costs money to demand abstinence among people who are not ready to be abstinent. And conversely, the basic norm of treating drug users as basically as human beings who do not deserve to be discriminated against or punished simply because of their drug use, that's an effectively inexpensive strategy, right? Allowing people, all sorts of basic things of just getting the state out of the way so people can operate in their own self-interest and protect their own behavior. Many elements of harm reduction, in fact, will save government substantial money at the same time as they save lives and reduce disease.
Excellent point. Anyone got anything to say on the specific point about tobacco harm reduction in sub-Saharan Africa? I will confess it's not an area that I have a great deal of knowledge on.
I think a lot of the principles are going to be the very same as you'd have anywhere else. I mean, what is a very pragmatic approach to take? What is it people are doing? What's available in terms of reducing the risks? What are the policy options that you need to have available for them? So, places that are banning alternatives, making them far harder to get, or misinforming the public, it's the same problem as you have anywhere else. Meeting the needs of consumers, you've got a very entrepreneurial part of the world. Give people the ability to meet consumer needs with lower risk products. Why aren't we seeing, in some of the countries where oral tobacco is already established, why can't we see low risk oral tobacco products? They exist. They're really inexpensive to make. They're much cheaper than cigarettes to make. How do we create an incentive for that and for more entrepreneurial activity to meet needs with products that don't kill people?
I think we also have to be aware of where harm reduction and drug law reform intersect, so that when one looks at what South Africa did over the last few months in banning both alcohol and tobacco products, all tobacco products, I believe, and they were introducing a prohibitionist policy. And what we know about prohibitionist policies is that they can be successful, especially in their earlier periods, in reducing cumulative use. But they rapidly generate all sorts of prohibitionist harms: black markets, more dangerous products, diversion of law enforcement resources to try and stop black markets, and all this sort of thing. And I think we saw in South Africa that with the prohibition of cigarettes, that you began to see these illicit markets and people engaging in more dangerous activities in COVID risking activities in order to obtain cigarettes from sources which were no longer easily available. So, when we talk about tobacco harm reduction, we hope that sufficiently robust tobacco harm reduction policies will ultimately drive down the consumption of cigarettes, of combustible tobacco products dramatically. There's every reason to believe they would. But at the same time, the basic principles of harm reduction should say that no matter how successful we are in driving down combustible tobacco use, we still should stop youth of banning the sale of these products to adults.
There's one other question that I have here. It's more an observation, actually, which may resonate with some of us, about harm reduction isn't quite the same as preventing or controlling. Preventing or controlling are the two most commonly used by policymakers when they're attempting to address a way to end or combat a disease. And I certainly think whenever, or although I would add it actually in the UK, when we talk about drugs, we seem to have an addiction to talking about tackling drugs. We like to tackle drugs. But yeah, the preventing or control, and perhaps harm reduction doesn't lend itself perhaps in the same way as you were talking about earlier, Ethan, to that sort of phraseology. Doesn't necessarily make good speeches.
You know, I'll tell you, I mean, sometimes I hear people sort of contrast tobacco control with tobacco harm reduction. And I resist that sort of definite labeling it that way. I tend to see that we're all involved in tobacco control, and there's a harm reduction approach to tobacco control, or a harm reduction approach to broader illicit drug control, and a non-harm reduction, a punitive criminal justice absence only oriented approach. So I see us really all engaged in trying to control the elements of these markets and the elements of these use. And similarly, when it comes to prevention, if people want to use that phrase, I mean, it's obviously the case that if you can, reduce the number of people or prevent people from getting involved in a risky activity in the first place, that's generally going to be a good thing, so long as they don't substitute other dangerous activities for it. But what I really tend to focus on is not so much preventing the use as preventing misuse. So if people are going to engage in activity, let's try to prevent the more risky elements of that activity. Let's try to reduce the more dangerous elements of that consumption. And I think that's a way of not getting so caught up in like prevention versus harm reduction, control versus. It's really about understanding that there's a harm reduction approach that cuts across the board.
Yeah, if I can just say, I've written various papers on this over the last 20 years or so, and I think that anytime you find any cause of death, injury, or disease, logically, there's just 4 ways to deal with it. You do things to try to get people to never engage in the activity. You do things to get people who are engaging in the activity to stop. You try to protect third parties from the hazards of that activity. And you do things to reduce the risk for people who are still going to deal with it. And it doesn't matter what the topic is, you look at all of those things and decide pragmatically what's the most effective way to do it. So, David, if you said that you're really keen on paragliding, I might say don't take that up. It's really dangerous. Have you tried chess instead? If you're already doing it, I might try to dissuade you from doing it. To say, have you tried road biking? How about you just stop paragliding for a couple of weekends and see how you are? If you're still going to be doing it, I say, can you try to do it in a place where you don't crash into other people? And if you insist you're going to do it, I might say, based on all the research I can see, this is the safest place to do it. And here's the equipment you should be wearing while you're doing it. And we do that on everything, whether we're talking about sporting activity, we're talking about automobile use, we're talking about drug use, we're talking about sexual behavior. We're trying to figure out what can we do to most pragmatically reduce risk where we find it.
Yeah, it's a really powerful analogy. I think we're coming to the end of the questions there. Heard a lot in there about compassion, the importance of evidence, an awful lot on pragmatism. But I think Cinzia's point particularly resonates, I think, with me on the fact that we need to carry on fighting, because even in countries where we think we've got advanced policies, we still need to push further on them all the time. But thank you very much for taking those questions, and thank you very much for your presentations.
Well, thank you for having this conference.
Yeah, and to be at one of these conferences and not be jet lagged. Thank you.
Thank you.
Hi, I'm Jim McVeigh. I'm Professor in Substance Use and Associated Behaviours at Manchester Metropolitan University. I'm here with my colleague, Dr. Hannah Timpson. She's a reader in Socio-Economic Engagement in Health at the Public Health Institute at Liverpool John Moores University. We'd both like to thank the organisers for inviting us to speak at this conference with the presentation entitled "How do we ensure compassion is not lost at a time of austerity?" The focus of this presentation is to explore the impact of service cuts on physical and mental health outcomes and understand the importance of compassion and empathy in an age of austerity. The drive for efficiency has seen most areas of public spending reduced, but has particularly hit welfare and social care. It's disproportionately affected women, children and the socially disadvantaged and has caused a great misery. Increasingly, people are presenting to health services, in particular primary care, with symptoms of anxiety and stress exacerbated by their personal circumstances. This can include eviction, homelessness, debt, rent arrears, reliance on food banks or transport costs. Those lacking the skills or experience or the technology that many of us take for granted being particularly vulnerable. Strategies that focus on invest to save are not implemented, resulting in short-term savings but longer-term implications for health and social care. This is a common feature in city life in 2020, beyond the UK and certainly not unique to Liverpool. However, it's in the northern English cities, such as Liverpool, where we see how austerity has particularly hit hardest. We can't escape the historical background of the city of Liverpool. Its industrial decline to a low point of the 1980s. And at this point, when compassion and innovation came to the fore in tackling the unprecedented rise in heroin use amongst the unemployed and the spectre of HIV. It was the passion and compassion of key individuals within the city that averted a disaster at this time of austerity. It's important to remember that the compassion was not limited to health and social care professionals or to activists, but in senior figures in policy, academia, the police and the church. An important element of the response to this challenge and a valuable lesson to take forward is the authentic voice of the people in those communities most affected. Liverpool continues to be disproportionately affected by austerity measures. The numbers are staggering. Liverpool has lost nearly £500 million over the last decade. 2/3 of the city's budget has been taken, which equates to £816 per head, while the city of Oxford saw an increase of £115 per head. It's within this context that we give a voice to those living in the current climate.
We're going to give some examples from research that we've carried out across the Liverpool City region of how services and organisations are finding it a challenge to deliver compassionate services at a time of austerity. The examples that we're going to provide are from research carried out with third sector organisations, groups and networks that really found the challenge of a lack of investment in the infrastructure made it difficult for them to provide sustained support for the people within the communities that need it the most. We carried out research with a range of different people, including providers of services based within the community and also a range of commissioners and other stakeholders from statutory organisations. Our research found that there was an evidence of a reticence for people to work together across the sectors, including statutory and non-statutory, despite there being multi-agency partnership working advocated as really important in tackling the challenges faced by austerity. One community provider gave the example of how they felt that they were almost giving their work away for free, which took away the value and created an economy of resentment. Another commissioner described how they want to get the most out of contracts, but not until it snaps. Another provider felt that statutory organisations were highly sensitive to challenge and were not necessarily wanting to work together to come up with solutions. And a stakeholder from an organisation described how it was important to allow people to have time to readjust to system-level changes. Jeff's story is an example of how difficult it can be to provide the support for people and to give them the options of attending the services that they might choose to attend. Jeff was attending a day centre and was getting fed up of it, and when he wanted to try something new, the social worker suggested a trial period. However, the system didn't enable him to do this because the direct payment was allocated to the day centre. In order for him to attend the voluntary organisation, the direct payment would need to be transferred over to the other service. However, this would have resulted in Jeff losing the place at the day centre. And his social worker described how Jeff really wanted to try new things, but the flexibility of the system isn't allowing it. A number of challenges were also raised across the research that we carried out that really illustrated the impact of a lack of investment in the infrastructure on the environment and communities in which people live. This was seen to have a real negative impact on the well-being and the aspirations of people living within those communities. For example, people described how the resources weren't appropriate to manage the people living in a particular community. There was also discussion of mistrust around administration of the welfare system and how that was a barrier to engaging with people within communities to make change. There was also an example provided of a particular community where fragmentation and disconnect was felt to be experienced, and that the people living there were almost feeling like they were second-class citizens. A number of challenges were also raised by the people that we spoke to that related to sustainability and risk. And again, this was particularly relevant for the people that we spoke to who were representing charities and third sector organisations. It was clear that the impact of austerity affects the organisations who deliver the community-based services, and they are supporting people who are experiencing physical, environmental and psychosocial problems brought about by austerity. It's really important such organisations are relied upon to meet the demand, but they often don't have the sufficient resources or expertise, as described through interviews that we carried out with some of the providers, and some examples of quotes are provided here. Examples include where providers want to engage and provide support, but they don't have the expertise or the experience to provide very intensive support that's required. And they really need wraparound support from wider services to ensure that this is given and provided. One provider described how they were worried that a big organisation was going to come in and take over, and that they weren't necessarily going to have the knowledge, compassion and understanding about the local community that they would as a local organisation. One provider felt really strongly that they didn't want to be reliant on statutory funding. They didn't want to be owing to the council for scraps of a couple of funds to make a change. They really felt that they were able to be innovative, to demonstrate the change that they could bring about, and they could be resourceful, change society by encouraging society to change themselves. The research that we carried out explored some examples of how interventions and initiatives have been delivered to support people who were affected by austerity. And it was really clear from the research that we carried out that solutions need to be appropriate and sustainable. How can we deliver efficient and effective change whilst ensuring that compassion is not lost? It's really important to have a sense of the wider picture and not to make quick decisions that might save money in the short term but have longer term implications for those people affected. These are two quotes from people who describe the impact of being workless but provided with opportunities to be in work, and how the quick decisions that were made weren't the most appropriate for them. One person talked about the impact of going into a job that had 0 hours contracts and the implications that that had for them. Another person described how they were encouraged to take a job in a factory after their business collapsed, and they said that that was absolutely the worst thing that they could have ever done in their life. The research that we carried out across the Liverpool City region demonstrated some really great examples of how efficient and effective change can be delivered at a time of austerity whilst ensuring that compassion is not lost. Key to this is investing in community-based supports. A wide variety of organisations provide excellent support if the infrastructure is there to support them to do so. It's really important to recognise that measurable change can take time and that services are invested in with appropriate length of contracts and infrastructure to ensure that they can deliver services over time. It's important that local strategies are delivered and are reaching those people who are most in need in order to address and not exacerbate health inequalities. These are two quotes from the research that we've done that really illustrate those points really well. One representative from the Merseyside Police described how community-based services and organisations are more likely to get over the doorstep than police and other statutory services. They're able to go in and identify vulnerabilities very quickly. A social landlord also described how it's really important to recognise that change takes time and that measuring services on inappropriate indicators means that funding might be taken away before that change is ever seen to be achieved on a wider scale. This person gave the example that if somebody starts living a more active lifestyle, the impact on society is not going to be realised until that individual has lived their entire life. All that you can do is measure small steps forward.
We're in an unprecedented situation. Austerity has been magnified by the current COVID-19 pandemic. Cuts in services have resulted in significantly poorer health, and the erosion of health and social care architecture has significantly impacted on the outcomes for patients. This is despite the commitment and care of those delivering health and social care. There's been no shortage of compassion at a local level, although this has not always been evident in central messages. For many living on minimum wage and relying on local transport, the message to use the car or bicycle is neither practical or sensitive. COVID-19 policy that allows a paid nanny to attend an employer's house but does not allow an unpaid family member to provide help or support to someone shows a lack of understanding of those who are currently struggling. We have the contradiction of orchestrated clapping of healthcare workers and terminology such as heroes, while many of those workers are not paid a living wage or provided with adequate protective equipment. However, the lack of compassion in charging migrant healthcare workers for their own NHS treatment may have gone too far. The current pandemic does provide an opportunity for a new approach to some of the enduring challenges facing cities. A drug treatment system that has a greater focus on self-management and personal responsibility may result in significantly improved outcomes for some, provided that there's adequate support for those who require it and that those decisions are based on need and compassion and not cost-cutting exercises. The introduction of accommodation for all those who were homeless at the point of lockdown was a landmark decision, but this needs to be built on. We need the authentic voice of those whose life is blighted either directly or indirectly by austerity. We need to understand their situation, and we need to provide the opportunity for their voice to be heard to promote compassion from the wider society.
We just want to end with a quote that really illustrates the importance of being able to deliver compassion at a time of austerity, the importance of investing in our local infrastructure and our local communities. This quote was provided by a provider working in one area of the Liverpool City region, and they described how the town centre that they worked in didn't have a particular coffee shop. And they said, if people don't feel that their town centre is worthy of having a high-end coffee shop, How do the children of the town or the population think they're any better than the pound shops on offer to them, or the lack of choice, or the charity shops, or decline and decay? You're dealing with a mindset that feels left out and left behind. They get embarrassed, they're not proud of their town, they turn to crime, drugs and gangs, or try and find easy ways to deal with life. Thank you for listening. Please don't hesitate to get in touch if you would like any further information or if you have any questions.
Good morning, good afternoon. Thank you very much for having me here. Being based in Warsaw, I very much regret we cannot meet in person in my hometown as it was planned. But at the same time, I'm glad the organizers decided to host an online event and focus our attention for a while on urban public health policies. COVID pandemic is actually reminding us once again about the principle to think globally but act locally. It applies to drug policy, which is my field of work. And when we look at the countries that are rightfully praised for their drug policies, like Portugal for decriminalizing drug possession, or Switzerland for providing very wide access to drug treatment and harm reduction services, we seldom realize, or we don't remember, the reforms started at the local level, with courageous and dedicated physicians, NGOs, mobilized local communities. In Portugal, before the government established in 1998 a group of experts who prepared the basis for the national reform, already in the early 1990s, small teams of street workers, needle and syringe exchange programs and low threshold methadone programs started to operate in Lisbon, in the district of Casal Ventoso, known for the widespread presence of drugs. In Copenhagen, in Denmark, the Street Lawyers Organization that many of us know quite well, for a long time advocated for opening a consumption room with no result. So after conducting a detailed legal analysis that proved that there would be no violation of the law, a project of mobile injection room was started without waiting for the green light from the authorities. So what could the authorities do? They created the legal framework which allowed for opening injection facilities, including age 17, the biggest one in the world, at least at that time. A bit more recent example comes from Eastern Europe, from the city of Sumy in Ukraine, where a safe consumption room was opened last year with municipal support, hopefully paving the way for similar initiatives in the region, since this is the very first drug consumption facility in Eastern Europe and Central Asia. Most of these, but also some other examples, have been covered by the Lessons for Drug Policy series published by the Open Society Foundations. So I really encourage you to check our SEF webpage and dig a bit more into the history of these pragmatic and compassionate drug policy reforms. What I myself found interesting was that severe public health crisis years ago was quite often the beginning, the reason behind many of these successful stories. In Portugal, a Eurobarometer survey conducted in 1997 showed that drug-related issues were perceived as the country's main social problem. But the first state responses to these critical situations were usually completely counterproductive. That is, intensifying repressive measures. Even in Switzerland, the abstinence-oriented drug law introduced back in the 1970s not only defined rigorous criminal sanctions, but it also prohibited the provision of sterile needles and syringes. So before the states did the right things, these were the local decision makers, local medical staff, local social workers, police officers who had to deal with the problems on the streets, in their districts, the problems, but also the tragedies they could see. And they were the ones who could not afford waiting endlessly for wiser solutions from the state level. Therefore, they created their own. In Zurich, in Switzerland, 300 physicians risked losing their medical licenses, but they decided to still distribute injection equipment to people visiting the so-called needle park, the place where even up to 1,000 drug users would gather every day. And in a way, we can observe a somewhat similar situation nowadays with the pandemic, when in many places, these are the local clinics, local hospitals, social workers, outreach teams, local communities and their allies who are at the front line of the fight with the pandemic, but also they are the ones to respond to the needs of the most vulnerable groups. And actually, they are the ones who immediately started to think outside of the box. Harm reduction services today very often provide not only needles and syringes, but they also distribute food, drinking water, hygiene products for women. In many places, in order to meet their clients, harm reduction workers decided not only to go outside to do the outreach work, but they're also right now buying vans to start the mobile units, or they are opening their services outside of the buildings in tents. A UK-based NGO release prepared very interesting cards called Essential Journey Cards for clients of harm reduction services and drug treatment units. So when they need to leave home, they can take the card with them, and when stopped by the police, they're somewhat safe, and their presence outside of the buildings is justified even at the time of the lockdown. The card simply says they have to go to pick up their medication or harm reduction equipment. I was also really encouraged to hear from the drug reporter that the city of Barcelona opened shelters for homeless people who use drugs. Therefore, they are denied access to other shelters. So right now, thanks to the city, there are 70 places available for men and women who live with alcohol or other dependencies. In many places, OST programs nowadays are allowing for bigger substitution take-home doses, something that has been denied for quite a long time. And even in the drug policy spheres that do require mainly state-level reforms, I'm thinking about decarceration, decriminalization. Even in these spheres, some improvements can be achieved at the local level, at least to improve incarceration conditions, for example. A human rights association, Antigona, that focuses on the penal system and closely monitors the situation in prisons in Italy, recommended that each penitentiary facility should purchase smartphones and prepaid cards to allow prisoners for regular daily phone or video calls with their relatives, with their families during the COVID pandemic. Let me show also a very welcome novelty that we can observe at the streets of Poland nowadays, that is deprioritization of the non-violent drug offenses by the police. When the police became occupied with other tasks linked to the lockdown rules, they simply resigned from stopping people to check their pockets for drugs, something that activists and advocates here in Poland have been advocating for years. So right now is the time for NGOs to monitor the situation, to collect data, to closely observe what is happening on the streets, to build a strong argument for the criminalization for the post-COVID times. I actually wished to stop here after sharing these encouraging examples that are coming from cities all over Europe, and they can show that actually cities can be incubators for very good practices. But there is also the other side of the coin. COVID pandemic has created some space and definitely a need for creativity and innovation, as crises do. But it is mainly posing threats. In addition to the public health, social, economic ones, in some places it has intensified populist and authoritarian tendencies. I'm thinking mainly, but not exclusively, about Central and Eastern Europe, about my home country, Poland, about Hungary, Bulgaria, Russia. The pandemic provided a pretext for the authorities to impose restrictions, resulting in the space for civil society severely shrinking or even closing. NGOs, in particular these that are perceived as critical to the authorities, these that work in the areas treated as controversial or morally dubious, HIV, AIDS, harm reduction, drug policy, sex work, LGBTQ communities, women's rights, etc., etc., they have already been targeted with the legal changes or smear campaigns. We could see a lot of that happening in Hungary, for example. When austerity measures were to be put in place, and actually we can expect more of them to come, these NGOs were the first ones to experience financial cuts or even to become ineligible for funds distributed by the state, regional, or municipal administration. In some cases, they had to close down, as it happened with harm reduction providers in Budapest. These are the organizations, the groups, the communities that have been investigated by the police, as it happened to the Center of Women's Rights in Poland, or by the governmental audit offices, by prosecutors' offices. We've seen tons of such cases in Hungary. Also, they have been attacked vocally, for example, in the media, by the media, but also personally, physically. Their offices, staff members, or volunteers have faced attacks. And right now, they're also punished for providing information around COVID, around the pandemic, and the safety measures. Unfortunately, I'm afraid we can expect even more of this to come. Therefore, to summarize and to come to an end, I would like to stress that I believe cities can serve as incubators of good practices. They did in the past, they're doing so now. But to use the potential that exists at the municipal level, we need all actors of the city level work to be included in that process, to be given a chance. And for that reason, they simply need to exist, to be safe, be adequately funded, and be listened to. Today, we need to remember about solidarity internationally in the whole sector, about the need to build very broad human rights coalitions. We have to educate and inform so the society understands that accessible harm reduction, wise drug policy, strong communities are now even more important, even more needed than ever. And to close, let me also say that I've shared some of the European examples simply because this is where I live, where I work, and when I can observe quite closely, on one hand, pragmatic solutions and compassionate attitudes, and on the other one, the closing space for civil society and austerity measures driven by populism and authoritarianism. But of course, lessons can be learned from other regions as well. I look at the encouraging stories of community mobilization or broad cooperations that come from Latin America, for example. So let's look around for inspirations. Thank you for your attention. Stay safe, stay at home if you need and if you can, but let's make sure, as someone said, let's not allow the revolution to be quarantined. Thank you.
Hi, hello, good afternoon, everyone. Thank you for joining us for this Q&A session. So my name is Katarzyna Kowalczyk, for those who joined us lately, and I'm here with Jim McVeigh, who's professor in substance use and associated behaviors at the Manchester Metropolitan University, with Hannah Timpson, who's a reader in socioeconomic engagements in health at the Public Health Institute at Liverpool John Moores University, and Magdalena Dąbkowska, who works over a decade in area of drug policy. Hi.
Good morning, good afternoon.
Hi.
So our speakers are looking forward to answer your questions, and we've already have some. So let me just start with the very beginning. So in all of your presentations, you addressed the issue of the importance of collaborative activities. So the pandemic itself showed us sort of the power of collaboration. So the question I have in here is, what could be done to improve multi-sectoral cooperation? Because we have heard, and I think it was in your presentation, Hannah, about the mistrust between various agents. So if I could start with you, Hannah.
Yeah, so I think one of the key issues that we found is where collaboration works well, it's when it's done in a true sense and it's not at all tokenistic. So I think that's really important for a collaboration to work well. It needs to be a partnership and everybody needs to be treated as equals. Mm-hmm. So in the experiences that we've had with our research, people have had negative experiences where they haven't been valued, their voices haven't been truly heard, they've been told that their voice would make a difference, but then actually it doesn't. And there's so many communities that we've worked with who have been told, if you work with us, then we'll make changes, and actually nothing really happens that's long lasting. So it might be a short term change, but the investment isn't made in the long term. So I think that's probably one of my overarching key messages, is that it needs to be a valuable, true and equal partnership.
Right. Jim, Magdalena?
Yeah, I mean, for me, one of the key things is around stripping back what you believe or what you go into it, what you know to be true. And being willing to listen to other people's truths, and to accept the fact that even with the best of intentions, when you go into any kind of relationship, probably what you want to get from it, or what you think others may want to get from something, isn't a reality. Mm-hmm. In reality, when you go into something around whether it's around drug treatment or drug interventions, for most people, the drugs aren't the issue. I'm not saying they don't care about those things, but there's a lot more other things of more importance, or that we would have to get through before we ever touch that issue. And it works either way. This, I think, is true with working with communities, but also with working with other partnership organisations. You know, we may feel we know what the police and what they're important to them is, but we're not. We don't wear their shoes. We don't know what their real primary objectives are. And I think it's stripping back what we believe we know.
Mm-hmm. Yeah, you're absolutely right, Magdalena.
Thank you. So building on what Hannah and Jim said and agreeing to everything that has been already said, I would say let the partnership and the collaboration be inclusive, to have around the table all actors who are anyhow engaged in addressing the problem. If we think about the city level, then these are usually the authorities, the decision makers, law enforcement, definitely NGOs, outreach workers, but last but definitely not least, the community members, people who are affected by the policy, or whose voice is quite often marginalized, unfortunately. While we should always remember that phrase, nothing about us without us, and include everyone who's interested, include and listen to their voices, definitely. I haven't touched that in my presentation, but there's a very nice example of Frankfurt in Germany, mm-hmm. that have a long-lasting cooperation of many different actors that started years ago, but that group meets each week or bi-weekly, very, very regularly for a long, long time, that allows them to update each other and to be responsive to the changing situation. I think in nowadays world of COVID, the situation is changing very rapidly, and we need to adjust to whatever is happening.
Well, thank you for this example of successful response to, because this is something which is also very, very interesting and very important nowadays. And I think you've already, all of you, answered another question we had about the authentic voice of those affected. So, and how can this voice be amplified? But you tackled as well a very important issue of sustainability and long-term perspective in planning. And we have a question with regards to what you said in your presentations about successful responses to pandemic with regards to rough sleepers and homeless people. And the question is, how confident are you that those steps taken to improve support for rough sleepers will continue? So, Jim, Magda, Hannah.
Anyone who would be optimistic. Well, they are definitely the ones that should be capped and that should not be treated as one-time response. But of course, we cannot be sure about that. This is something that we all the advocates need to work. My hope is that COVID, in a way, showed or let people show a lot of compassion and solidarity. So this is something to build on and to keep it going. But at the same time, we all expect the austerity measures to be increased. And then probably that will be the moment when it becomes challenging.
Jim, would you comment on this?
Yeah, I mean, I think obviously the steps that were taken in the UK over bringing in accommodation for those people who are homeless. But when you start to unpick it a bit, it was only those people who were homeless at the point of lockdown, not during lockdown. So immediately, I suppose it shows a lack of understanding of what that situation is. Another thing, there were twice as many people as they expected, which is, and I found it particularly interesting a few days ago when we heard about the numbers of people of homeless nationally, when we don't know how many there are locally. I don't know how they know how many there are nationally. But there's always, well, we know this, we've got this boxed off now. We've given the homeless somewhere to live. And then we have a prime minister who says that, you know, if it doesn't work out, why don't they go and stay with their family or friends? You know, and it's that level of sort of ignorance that makes you feel sometimes that you go one step forward and two steps back. And I know that realistically, we need to take the wins where we can and hold on to them and build from there. But each time you hear it being undermined in some way, you feel that is creating as much damage as many of these good things are creating good.
You're right. And Hannah, would you like to add something?
Yeah, I think just to kind of echo what's already been said around, there's a real, in terms of the recovery response, particularly here, I think there's a real importance that we look at the longer term implications and that we don't just look at these are the short-term solutions, this is what we need to do. Obviously, within the response, you know, there has been some great examples of positive action that's happened. And what we need to do is to learn from that. And I think that one of the risks is that in terms of going to recovery, that there'll be some decisions made that might undo some of that good work. And it is about understanding what the long-term implications could be. And some of that, from an austerity perspective, it's around, you know, that whole invest to save argument. You know, you sometimes might not necessarily see, you know, a financial implication immediately, but if you make the right decisions now, in the longer term, you'll get that payoff. So I think it's, yeah, definitely kind of just echoing what's been said already and building on the need to have long-term investments.
The next question is addressed to you, Hannah, directly. You seem to have had success in engaging with the grassroots communities groups. So any tips on how could it be replicated?
Yeah, I mean, for us, a lot of the research that we do is with people who might not necessarily access statutory organisations, and sometimes they might be kind of classed as hard to reach. Nobody's hard to reach, everybody is out there, you just have to go to them. And sometimes the best way that we find to do that is to work with those grassroots organisations, so third sector organisations, voluntary, community, faith, organisations, and it's about making use of your networks, building relationships, establishing relationships, and when you do, it's about maintaining that, keeping hold of that, not doing anything that's tokenistic, and really placing value on the relationships that you build. And a lot of the work that we have done with people in communities who have been very isolated, suffering with extreme mental health issues, exacerbated by poverty and the associated factors there. A lot of the ways in which we get to speak to those people and find out, what do you need? How can we support you? How can we ensure that inequality is not exacerbated for, those populations? It's going through the third sector. It's going through community organisations. And I think once you start to build relationships with people in networks, then you kind of, it's such a great way to work. And I think it's really important that we do place value on making sure that we invest in the infrastructure that we have in the third sector, because those grassroots organisations are the ones that often are counted upon to make the difference, but not necessarily always invested in that longer term.
Any other tips?
Any other what, sorry?
Tips for
engaging.
Jim?
Could I come in? And they're not my tips. They're things that I've seen Hannah do. And it's the amount of groundwork and that preparation on the particular topic, but also how to engage with them, and then using imaginative ways to engage with them. And I know, because I used to have to sign off requests for the things that she used to purchase, including various toys, games, whatever. And not using them in a patronising way, but using them to let people express themselves or to break down barriers. And I think it's what she dismisses it as just going out there and making it happen. There's that background work that she does, which has been so important.
Thank you. Magda, another question is directed to you. Do you think that the pandemic could be a defining moment for the future of harm reduction, as the AIDS epidemic was before? That's it.
Well, I'm not sure if it could be a defining moment, but definitely that can be a moment when we use a chance. I mean, it's also difficult to speak about the pandemic as a chance, but in a way, it can be seen as an opportunity. Yeah. So I do believe that this is the moment when a lot of things that have been clear for us are actually becoming visible to the public, to the decision makers. We can see that things are possible, that they're not damaging the safety of the public, of the citizens, for example. So I do believe this is the moment that we can use. But who knows how that will happen? I mean, there's of course a lot of work that needs to be now done around that. I can see NGOs, organizations really doing a great job here. But it's not only about delivering services right now. This is the most current, the most urgent need, and I can see people being really innovative, thinking outside of the box. But then we will need to spend some time, maybe when the situation becomes a little bit stabilized, to monitor the change, to report, to collect the data, as Hannah said, we need to think in the long term. So there will be a moment when we will be able to use whatever we are experiencing right now and to build upon that. But there's of course work to be done for the advocates, for the organizations. I once again would like to remind what has already been said here about the engagement of the communities, of their voices. They do need to be able to speak for themselves and advocate for their needs. They're the ones who know what is needed. So I would find it really, really important.
Jim, Hannah, would you try to address this question?
If I may, and I suppose it's, I don't mean to come over too pessimistic, but in many ways I hope it's not defining, because my fear is that the definition would be where we saw a lot of the NGOs and voluntary sector decimated as a result of the economic impact that COVID may have. And while I accept, the hardship and the pain of people suffering directly from COVID, I am very concerned about what the economic impact may have on the most vulnerable of people and the most vulnerable of organizations.
Yeah, that's a good point. Hannah?
Yeah, just to pick up on that, really, I think that's definitely been the experience that we've had so far working with voluntary community, faith groups and organisations, is that they have adapted so quickly. They've adapted immediately and really effectively, but they are the ones who are now most vulnerable in terms of potentially, they're going to be asked to pick up a lot of the pieces, I think, in terms of the recovery element. People in the community, people in their homes, being supported by third sector organisations, and yet they are most vulnerable and they don't necessarily have the long-term resources, financially, staff-wise, volunteer-wise, to be able to provide the support that I think is really needed. So there is a risk there at the moment, and we're doing some research at the moment to try and understand what some of the implications are for grassroots organisations in the third sector, to see how their sustainability and their infrastructure might be potentially, put at risk by the current situation.
This question is not on a list. It's my question, but I feel like I can address it. And it's a question to you, Hannah, about the results of your study, because they are very interesting. And I would like to ask, is there anyone, policymaker, that you use the results of this study, for example, for the future planning? Like, do you share these results and they are being used?
Yeah, that's a really, really good question. So the research that we presented is from a number of different projects that we've done across the Liverpool City region, but very specific to sort of issues around compassion and austerity. And what we tend to do is we're commissioned to do the research by local authority or health and social care organisations, so statutory organisations. And what it enables us to do is to then bring that voice back to the table. So one of the examples that I talked about was a social prescribing project that we did, and we actually brought the providers and the commissioners together to discuss the results of our research, to talk about what would that mean for the future. And so we had developed recommendations independently as researchers, but we found that the providers were saying the same kinds of things but hadn't necessarily discussed it, and the commissioners hadn't really had a conversation with them. So we did a bit of a kind of a session with them using some toys that Jim described before. So we used Lego. We started off, we had directors of public health, senior leaders in health and social care, and then third sector providers. And we facilitated that session, and we started off with just asking them, build a Lego model to tell us what you want social prescribing to look like in this area. And then it kind of was really then quite nice and relaxed. And then we started to talk about the research shows this, how are we going to address it? What are you going to do as commissioners? So that then helped to build a commissioning specification that was then very specific to the needs, but also the provision available within the area.
I think this is an excellent example of how to bridge the gap between the research and service deliverers. So thank you for it. And from what I can see, the last question is directed to Magdalena. Are there any examples we can look to where populist and authoritarian governments have actually favored a harm reduction approach?
Not that I'm aware about. Well, the authoritarian regimes, they, in a way, they have proven to be maybe better, delivering better in terms of fighting with the pandemic. Mm-hmm. But I would say that the costs of that are so huge. And that was not necessarily in the harm reduction spirit. That would not be the way I would recommend to go. Unfortunately, as I mentioned in my presentation, wherever the space for civil society is shrinking, then we'll see A, the communities, B, the organizations that deliver services and provide care to them, getting more vulnerable. So as Hannah said, especially these places would need a lot of our attention. So not really.
Mm-hmm. Jim, because you laughed when I was asking this question, would you like to?
It did. It was an ironic smirk. It wasn't a laugh. And it was. And I suppose, I mean, the one of the UK in the 1980s, when we had the biggest right-wing government that we've had until the current one, and we made, massive headway in cities like Liverpool and Manchester, and that wasn't because of what was done by central government. It was because it's what they didn't do and what they didn't bother doing. And in some ways, the greatest favour a central government can do is leave you alone, because the innovation and a lot of the progress, you need the funds and you need some of the infrastructure, but the big benefits can be gained locally. And in some respects, being left to get on with it can be a massive favour.
Mm-hmm. Hannah, any last words?
I guess, I mean, just picking up on Jim's point there, I think narrative is really important. And we've found in a lot of our research that the discourse, the narrative, the words that are used in policies are completely not the way that we would expect or talk in communities. And there's massive differences between what communities want and what policy says. So I think that there's work needed there as well.
Well, thank you. I think we came to an end of this session. Thank you very much for participation in our City Health online conference. And I so hope to see you all next year in Warsaw. Actually, I hope to see you much earlier. Don't wait until next year. Thank you. And one last information is I would like to invite all of you for our memorial lecture. Alison, Chesney and Killoran memorial lecture delivered by Marewa Glover. Thank you.
Thank you.
Thank you very much.
Hello, and we now come to one of the highlights of every City Health International Conference, the Alison, Chesney and Eddie Killoran Memorial Lecture. Today we're very fortunate to have Dr. Marewa Glover delivering this memorial lecture for us. The introduction was going to be delivered by Alex Wodak. Unfortunately, we've had technical problems, so we're going to have to put up with me reading Alex's words of introduction. I'll start off with how Alex describes himself, which I think is the epitome of modesty. He describes himself as a retired doctor from Sydney, Australia, with a long-standing interest in harm reduction, including tobacco harm reduction. I think many of us would agree that rather undersells his contribution to the field. Moving on with his words. 2020 is, of course, the year of a major plague. The COVID-19 epidemic is why the 2020 City Health International Conference is being held as a virtual meeting rather than having us gather in a fancy hotel. The world has had many plagues over the years, but this is the biggest for a century. Epidemics of infectious diseases, including plagues, have caused a huge toll of deaths and disease amongst Indigenous people in the New World. Many of these infections came from the Old World to the New World. Smoking cigarettes is another pandemic which began in the Old World. It increased spectacularly around a century ago after advances in manufacturing, advertising and marketing. It has also disproportionately affected people in low and middle income countries and Indigenous peoples. Smoking amongst Indigenous people is the subject of the talk you are about to hear. We are fortunate to be able to hear Dr. Marewa Glover, a Maori woman from New Zealand, who has made reducing smoking amongst Indigenous people her life's work. This talk at City Health International's 10th event is in memory of two very inspiring people, Alison Chesney and Eddie Killoran. Unfortunately, I never met either of them, but they certainly made a huge impression on the many people who had the good fortune to meet them or work with them. Alison and Eddie met in 1982. Sadly, they both died of cancer within 6 months of one another in 2006. Alison was 48, Eddie was 54. They were very well known and much loved figures in the drugs field. Alison Chesney and Eddie Killoran were pioneers of harm reduction. Alison had trained as a psychiatric nurse. Eddie had for a time struggled with his own drug problems. Alison and Eddie worked together for a better world, a world where people who wanted and needed help received high quality help without being judged. I am sure you all know John Lennon's words from Imagine. You may say I am a dreamer, but I'm not the only one. Alison and Eddie wanted a world where powerless people like them had some power, a world where powerless people get listened to. These days we talk about nothing about us without us. One of the huge differences between people who support harm reduction and those who resist it is the attitude to nothing about us without us. Harm reduction advocates like Alison and Eddie believe that much more is achieved when the experts and researchers work as equal partners with people with lived experience. The partnership achieves much more than either group trying to work without the other half. That's not the way that harm reduction opponents think. We recently lost another public health hero, Larry Kramer, the New York AIDS activist. We can thank Larry Kramer for doing so much for the notion, nothing about us without us. Our next speaker, Dr. Marewa Glover, is the living embodiment of that notion, nothing about us without us. She is the director of the Centre of Research Excellence, Indigenous Sovereignty and Smoking. She is New Zealand's leading Maori tobacco control researcher. She has over 27 years' experience working on Maori health research projects as an author of over 100 publications. Before establishing a centre in 2018, Dr. Glover was a professor of public health at Massey University in Auckland, New Zealand. Smoking amongst Indigenous people has been till now a pretty neglected area. Marewa is changing that. She is actively researching what works and what doesn't work to reduce smoking-related harm amongst Maori people and amongst Indigenous people in other countries. It is my very great pleasure to provide a virtual welcome to Marewa to this virtual City Health Conference. Thank you.
Thank you, Alex, for your lovely introduction. It is an absolute honour to present this year's Alison, Chesney and Eddie Killoran Memorial Lecture. And thank you to the City Health International organisers for inviting me. First, my disclosures. I have never received any funding of any kind from a tobacco or vaping product company. Many years in the past, I received consultancy fees from pharmaceutical companies on cessation medications. My Centre of Research Excellence, focused on Indigenous sovereignty and smoking, is funded by a grant from the Foundation for a Smoke-Free World. The content of my talk is solely my responsibility and in no way should be seen to be reflecting the positions of the Foundation for a Smoke-Free World. So first, one of the first and most important questions that an Indigenous person asks when we meet another person is, ko waikwe, who are you? But it's not your name we are after. We want to know what our relationship to each other is. Are you friend or foe? Are we related? Do we belong to the same tribe or tribes? Importantly, are you my senior, a person I should defer to? We look for a connection, something we share. So to start with, I will just tell you a little bit about myself, picking out bits of my story that help me connect to the spirit and work of Alison Chesney and Eddie Killoran. I was born to fight injustice, I think. On my mother's side, I am a descendant of the biggest Māori Indigenous tribe in New Zealand, who were the first to be impacted by the colonizers. Some of my ancestors protested and fought the theft of land, the laws that forbid them to speak their language, and the laws that banned their spiritual and healing practices. The colonization by the British of New Zealand was a process of theft, suppression, and violence that resulted in the English settlers and their descendants at one point being able to boast that they were the healthiest and lived to the longest lifespan in the world. They achieved that off the back of the Indigenous people and the land. The Indigenous people, meanwhile, were marginalized, belittled, scorned and made into a dependent working or even lower class. Despite the efforts of the colonizers to assimilate Māori, our Indigenous knowledge, beliefs, rituals and practices were protected, hidden if necessary, and passed on. Generation after generation have and will continue to fight to reinstitute our very different Indigenous viewing of the world. I'm telling you this because we believe that a person's roots, their socio-historical background, contributes to who they are. At a more personal level, my father was from a working class English, his father was from England, and his mother was fifth generation English New Zealander. Among many other things, he was abusive and violent towards my mother, occasionally towards me, and more towards my immediate younger sister. I did what a toddler does, what any young child can do when the person in control of your world is a tyrant. I comforted my younger siblings. I feared for my mother. I developed a deep sense of compassion and a distrust of him and an abhorrence of the abusive power. And I have ever since waded into fights where a physically larger bully was attacking a smaller or younger person. Many times I've put myself at risk, the most recent assault occurring just 2 years ago when I tried to protect some youth from some older men. There'd been a car crash and the older men were looking for retribution. One older man rushed into the crowd of youth and punched one of the boys. And I tried to get a photo of him for evidence for the police. He grabbed me around the throat and slammed my head down onto a rubbish bin. So that was a physical attack. In my older adult life, I've been more usually subjected to attacks that are from afar and more stabbing in the back by competitors in my area of research who are intent on sabotaging my studies and destroying my reputation and, if they can, my will to carry on. That instinct to rush in to protect and defend people who are being victimized, who are being unfairly treated, seems to be something I can't temper. And I don't think it's right to. Whether it's a single person in a position of power taking advantage of a subordinate, or a group who form a mob to terrorize someone or a class of people, whether it's the government of our day, the members of parliament who seek to elevate their way of life, their religion, and their culture over all others, I'll stand up to any of them. One of the things that has helped me survive was my education, studying psychology, studying domestic violence, studying the sexual abuse of children, colonization and racism, emotionally heavy and upsetting topics. But I developed an understanding, and there's security in that. To get away from the heavier topics, I thought that focusing on helping people stop smoking would be very worthwhile and far less hard on my health. And it was for 20 years of my career in tobacco control. But the last 7 years or so have turned vicious. Some people in the sector began lobbying to penalise people who smoked with fines, to deny them accommodation and employment, wanting to evict them from city centres. They wanted to mark people, make them carry papers, calls that should concern anyone with a basic knowledge of the historical oppression of peoples. The Indigenous people of New Zealand, Australia, Canada, the US, New Caledonia, I could go on, for example, have disproportionately higher smoking rates. And I had to object because these regressive, deliberately damaging policies would disproportionately hurt my people and other groups with disproportionately higher smoking rates, people with schizophrenia and other mental health conditions, and the lowest income group. Here we go again. Here's a group of mainly white, middle-class, well-to-dos wanting to sock it to them blacks, the poor, them scary people with mental health disorders, them homeless. So this isn't about smoking, I realized. They don't care about these people. They don't like these people. And then along came vaping. A few colleagues and I had already been lobbying for Swedish snus, a greatly risk-reduced alternative to smoking, to be made legal in New Zealand, but we hadn't been having any luck. And I just heard last night that we still are not going to get that even with the legalization of vaping. However, vaping, here at last, was a harm reduction product that was taking off among people who smoked, regardless of public health and regardless of tobacco control's opinion or assistance. It was great. But the slay 'em harder, bash them till they quit mob had said no to harm reduction. No, you quit our way or it's the highway. Your choice is quit or die. This just convinced me all the more that what was happening was no longer about public health. There was too much abusiveness internally in the sector, and towards people who dared to disagree, as well as towards people who smoked and vaped, the people we were supposed to be trying to help. This is another thing that helped me stay resolute. If people have to use abuse and attacks, if they defame you, lie about you, if they manipulate others or threaten others to silence dissent, then you know what they're doing is wrong. One of the spiritual resources Indigenous people had and still have that colonizers needed to destroy was our beliefs and practices that enabled us to discern right from wrong, truth from lie, integrity from corruption. At the beginning of my talk, I said the most important question we ask when we meet someone is, who are you? This is just an everyday example of one of the ways we seek to discern a friendly from someone out to steal from us or hurt us. Meeting face to face was another important practice because it gave us the opportunity to get a better sense of a person. We call it their ahua, their character. Face to face, you have more clues to watch out for, and spiritually there are more signs. You know, the feeling you get when your instinct about a person kicks in. We had a lot of cultural and spiritual protocols and practices that helped us protect ourselves and our families and our culture. An important piece of advice that helped me along the way was uphold your own tikanga. Tikanga are tribal protocols, or you could say principles, values. It's like your system of ethics. Firstly, you have to know what your tikanga is. You have to have some principles and ethics. And after 30 years almost in this business of public health, I'm sorry to say some people in public health have no ethics when it comes to what they are willing to do to people, to bend them to their will, to make them obey. Science is a system of ethics. There are research ethics, there are professional ethics and rules of behavior. And when professors do not abide by those ethics, for example, sexually harassing a student, that's a breach of professional ethics. Defamation is a breach of professional ethics. Appropriating science, for example, conducting a non-scientific opinion survey of a highly select sample of your colleagues and writing it up and presenting it as a scientific work with the intent being only to manipulate policy analysts and politicians. This isn't science. It's not evidence. It's simply a lobbying tactic. It used to be called propaganda. One of the negative consequences of this kind of advocacy research, we call it, these so-called studies or market research that are written in the language of a scientific study but methodologically are flawed, is that science itself gets eroded. Students should be taught to discern between a rigorous study and a piece of work that sounds like it's research. But so much of the shoddy not science has now been published that it's normalized the new genre, and the new generation of scientists are not questioning the lack of rigor, the glaring researcher bias. Well, it's okay as long as they write what the limitations are in the paper, right? We are well into an era now of overconnectedness, the Internet of all things, having public profiles on several professional and social media platforms. There has been an equalizing effect. Now anyone, regardless of qualifications or experience, can blog about any topic. This has worked well for the vaping community, who via face-to-face and online peer support have largely driven the mass exodus of people from smoked tobacco to vaping the greatly risk-reduced nicotine e-liquid. But poor old public health, stuck in the past, can't get a word in. I've been collecting tobacco control papers over the years that discuss how it was getting harder and harder to get the message across. There was too much competition. How do you get cut through? What do you do when the media are sick of the same old smoking kills message? The authors recommend getting creative, using street drama, recruiting community-based people to voice the message, mostly pre-prepared scripts, or better yet, get children to read them, an exploitation I really have never been able to stomach. We had to get louder, be more shocking, use blood and gore, show people with their throats half eaten away with cancer. We had to exaggerate the ill effects of smoking. We had to come up with something new all the time, latch on to topical events like recently, like COVID. Somehow get your message attached to these, whatever's getting coverage. Create days like World Smoke Free Day. We had to become celebrities in our own right, celebrity scientists. We had to get on TV. We had to get XXK plus numbers of followers on social media. For some, the pursuit of sainthood or celebrity and fame has become more important than whatever reduction of disease they originally signed on for. Just as an example, one prominent Anglo-Western professor of nutrition in New Zealand likened himself and his colleagues to Mahatma Gandhi. As the messages became more exaggerated, we moved further and further away from the truth. But the new generation of smoke-free workers didn't know the messages were exaggerated. Did we need them to know? No, because we need them to come across as authentic, right? One of the things I learned when I was briefly working in the field of domestic violence is that if there is no negative consequence for an act of violence, the abuse usually escalates. That's what's happened in public health. There's only been encouragement to do more, louder, go further, be harsher. There's no brake on the train. There's no accountability. People seem less willing to protest now and risk losing their job or being stabbed in the back, defamed, exiled and blacklisted from working in the sector, like what's happened to me in New Zealand. If public health keeps on like this, like a runaway train, where will it end, I wondered. Well, now we know. Public health has reached the apex of its power. I hope it's the apex. They have so much power, so much influence. They have managed to convince governments around the world to quarantine their whole nations. Not just the people who were infected or at risk of being infected. They quarantined the well. They quarantined the people not at risk of illness. They sometimes, with force or threat of enforcement, locked people in their homes or elsewhere. The damage, the loss of businesses, jobs, housing, the increase in deaths due to suicide and delayed surgery is yet to be calculated. This is another breach of ethics. The treatment should not do more harm than the problem you're trying to alleviate. Laws passed under urgency during lockdown have handed police unfettered powers to come into our homes without a warrant, to stop, question and detain anyone, anywhere, even in a supposedly democratic society like New Zealand. Many of us have felt a chill run down our spine, especially those of us who know what it's like to live in fear of a tyrant, or the police, or an authoritarian government who do not care about people at the bottom. A mistake we've been making, I think, for decades is to think that the war on drugs is about drugs, and the more recent war on nicotine is about nicotine. It's not about nicotine. Some people in public health and in tobacco control, those holding the reins at the moment, are waging a war on people. People they don't like, people they believe they are superior to. They will weaponize anything to brand people wrong, be it the color of your skin, your sexuality, your religion, or ethnicity. Oh, and if we outlaw discrimination on those grounds, then they will just switch to something else that isn't illegal, like discriminating against you on the basis of your body shape or size or weight, your lifestyle, that you smoke, drink alcohol, or eat junk food. Public health are constantly now marking people. It's like that schoolyard or workplace prank when someone sticks a sign on your back saying kick here. It's government-sanctioned bullying. No wonder our bullying rates and our suicide rates are so high in New Zealand and Australia. The way to stop this is diversity, to elevate and demand inclusion of a diversity of views, a diversity of scientific opinion, a diversity of experts need to be involved in deliberating decisions and policies. And consumers and the people who will be disproportionately affected by policy decisions must be heard. The nothing about us without us must be honoured. But it has to be real, not just the tick-the-box performance like the New Zealand Government Health Select Committee, who made us all submit to them while in lockdown about the vaping legislation here, only to have them change virtually nothing. Nothing. Their prohibitionist minds were made up. Valuing diversity needs to be real, not the roll out the brown carpet token effort it is now. Roll out the brown carpet is a saying we have, for example, when the white professors employ one brown person to front recruitment of brown people for their study. Oh, and they'll make sure they get someone junior, someone who doesn't realize they're being used against their own. There must be tikanga, there must be ethics, setting behavioural boundaries and to prevent abuse and corruption. And scientists corrupting the process should be sanctioned. There needs to be consequences for abusive acts. With the mess that science is in, we need more open processes like consensus-seeking conferences, not the echo chamber backslapping rah-rah meetings that tobacco control conferences have become. Research results should be free and openly available to the public and all other scientists. If even one professionally upstanding scientist, such as myself, the most qualified and most experienced Indigenous expert on reducing smoking among Indigenous people in the world, is blacklisted, as I have been by the New Zealand Government Ministry of Health, you don't have science, you don't have freedom, you have tyranny. If they will do it to one person, they will lose no sleep over doing it to 10 or 100 or a whole nation. I wish more people would battle for justice and stand up for people being exploited and manipulated, like Alison, Chesney and Killoran did, and like I do. It's no good saying anymore, as Shakespeare wrote, that the truth will out, that the truth will prevail. Times have changed. The liars are winning. The anti-vaxxers are winning. The anti-vapers are winning. Democracy is fragile. It is not assured. The atrocious and unscientific abuse of power many of our governments have just exercised should be all the evidence you need to question more, critique so-called scientific claims, help restore our right to debate without fear of abuse, help restore my right as a scientist, and therefore everyone's right, to conduct our research and publish our research results. Yes, the prohibitionists are prohibiting journals from publishing my work. Vaping is not controversial. It's simple. It saves lives. It's harm reduction. The corruption and suppression of science, manipulating politicians, lying to the public, that's what should be controversial. Thank you very much.
Hello, and I hope you enjoyed this online edition of City Health International. A big thank you to all our speakers and presenters. I think we've heard a powerful case presented as to why compassion matters, not just because it's a nice thing to do, but because it works. It makes a real difference. Likewise, I think we've heard a lot about the potential of harm reduction and the principles that guide harm reduction and how effective they can also be. And they certainly extend far beyond the world of drugs and alcohol. Marewa has reminded us of the importance of science and evidence and how that should guide much of what we do. I must also mention the team that have made this event possible. They've grappled with many technical issues. I think we can safely say going online is not an easy option. Now, we hope and are planning that next year we will meet in a more traditional format. But to help us with planning for next year, to help us think about what other online events might look like, we'd be very grateful if you could fill in the feedback form. There's a link on the website. Now, there is an incentive to complete this, which will be a free registration for next year's City Health Conference. So please do fill in the feedback form. Now, it's going to be some time before we can really evaluate the full impact of the COVID-19 pandemic. But what we can see now is that once again, it's the most disadvantaged and vulnerable members of our communities who get hit hardest, who carry the burden. And also that the principles of austerity, which many countries have followed over the last 10 years, have exacerbated that situation. Current events really should give policymakers, researchers, and service commissioners pause for thought. The economic impacts of the pandemic are going to place further pressure on health and social investment. If we are going to improve the lives and health of our cities, we surely need to improve political understanding, need to better engage the power of research and academia, and we need to support frontline service delivery better. Around the world, the last few months have provided many examples of exciting work which show just what can be achieved through collaboration. Many cities, including London, have undertaken outstanding work to get the homeless off the streets, into safe accommodation, and provided good quality support services to those individuals. Now, that's required many different organisations, central government, regional, local government, to come together to work with the voluntary sector and health services. The importance and urgency of effective responses swept away many of the normal barriers, but they also revealed the compassion that motivates many of us in our work. And I think this is nowhere more evident than in frontline service delivery. Despite the additional work they've been asked to do, despite the very real risks they have faced, I know many workers in the substance misuse and homeless fields who have felt enabled and empowered to get on and deliver substantial and real benefits to those they work with. And of course, the benefits extend to the broader community. So amidst the tragedy of the pandemic, we have large-scale and exciting examples of what can be achieved when we align all our resources together and work together. So for 2021, the theme of our conference will be COVIDopolis, urban health and harm reduction in a time of crisis. We invite you to send us abstracts for inclusion. There will be further details available on the website shortly, but areas of interest will include the lessons learned, opportunities provided to deliver effective and pragmatic responses, innovation in policy and service delivery. Of particular interest will be examples of multi-agency cooperation and positive community engagement. Now that's it from me. I hope you found City Health 2020 of value. Do please give us your feedback, and I very much hope to see you next year in Warsaw. Keep on doing the great work you do. Keep safe.
Thank you, Dave, for your comments, and I do really hope that we will see each other in 2021 in Warsaw. So now let's move for the final bit, Nick Crofts from Harm Reduction Journal. But before, I would like to kindly ask our audience to complete the feedback form, which is available on our website, cityhealthinternational.org, and which will help us to improve the quality of our City Health events. Thank you.
My name is Nick Crofts. I'm Director of the Centre for Law Enforcement and Public Health, and I'm a coordinator of the Law Enforcement and HIV Network. I'm also Editor-in-Chief of the online open access Harm Reduction Journal. The Harm Reduction Journal was begun in 2004 by a great harm reductionist, Professor Ernie Drucker. Its focus has been on the now traditional harm reduction area of decreasing the harm associated with the use of illicit drugs. We published research, commentary, opinion, policy in this area for the last 16 years. But harm reduction is not limited to harms associated with illicit drug use. And in fact, I would argue that harm reduction is a normal human response to intractable problems that won't go away and for which there is no immediate solution. We are, as a journal, therefore broadening our focus to include a whole range of other complex issues, usually behaviourally based, in which there is the potential for harm and for which there is no immediate solution. We now have sections in the journal covering harm reduction related to gambling, to alcohol, to tobacco, to drugs on the internet, to sex work, to incarceration, to human enhancement drugs, and we're constantly looking for new areas in which the journal can contribute. So we're now publishing research and commentary and policy across this whole breadth of harm reduction, very much in line with what the Global Public Health Network is doing. And we are associated with the Global Public Health Network and look forward to continuing to that association and continuing to work together across applying this pragmatic and effective philosophy across this whole range of human behaviours.